This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, here is a 70-year-old lady who has this phacolytic glaucoma. The pressures on presentation were about 45 and she was on treatment with anti-glaucoma medications and steroids for few days, and now she is scheduled for surgery. So this is a complex case. So when I approach such a case, I'd like to break down the complexities into individual points and try to address them. So in this case, I'm anticipating problem during creating a phorexis because the visibility is going to be poor and also the zonules might not be very healthy. So once the rhexis is out, the next would be to know the status of the bag. Since it's a long-standing cataract and it's in an elderly patient, I expect the zonules to be weak, and dealing with the zonular laxity is going to be a second challenge. Number 3 would be with the nucleus itself. The nucleus is of significant density and that is going to be a challenge on how do I divide this. Number 4, the posterior capsule is going to be extremely thin and flimsy and there is a high risk of posterior capsule tear happening in such eyes. And lastly, I need to have a backup plan to convert to manual small incision cataract surgery, that is to extract it through a scleral tunnel in the event of an intraoperative complication. So with these understandings, I have begun the surgery. I'm sitting temporarily and the surgery is being done under topical anesthesia along with intracameral lignocaine. The anticapsule is stained with trypan blue and the chamber is filled with dispersive OVD. I'm consciously making a sclerocorneal tunnel incision. The idea is to use the same incision to extend and extract the nucleus manually if the situation demands. As expected, as soon as I puncture the capsule, there is an escape of the fluid cortex and which in turn hampers the visualization. In such cases, I would always prefer to have a forceps to perform the rhexis since it gives better grip and control over the tearing of the anticapsule. I'm trying to avoid this calcific spot here, and because of that effort, my rhexis has become slightly smaller. So this size rhexis is not advisable to deal with this hard nucleus because a lot of manipulation is going to happen when trying to divide the nucleus and can stretch the rhexis, so it needs to be enlarged now. But before that, I would just like to clear off the field by using some aspiration to remove all the cortex which has come out so that the visibility improves. Once the field is clear, dispersive OVD is again placed into the antechamber, giving some amount of positive pressure that's more in the chamber and less in the bag, the OVD. Using the micro scissors through the side port, I'm giving a tangential cut to the rhexis margin beyond the area of this calcific spot, and I'm just hoping that the capsule behaves well. So this was the enlargement of the rhexis which was done. Still, it was not very big opening, but I think this should suffice for managing this nucleus. So let's see how things turn out. Now, knowing the zonular health of this eye is not so great, I decided to insert the CTR before proceeding to manage the nucleus. I believe that this would definitely enhance safety and provide much more stability during the nucleus manipulation. The CTR is gently inserted into the bag, nice and easy. Time to emulsify the nucleus. So in this case, the nucleus is going to be mobile, there is no epinuclear support, and it is difficult to grip it and chop. So these are the situations where my favorite chopping technique is going to be the horizontal chop technique in this situation. Because I need to get a firm grip on the central part of the nucleus, I would want to create a small trench using continuous torsional power so that I can hold the nucleus in the most central core part that's in this belly so it doesn't move around as I score the nucleus. When I'm sculpting, I'm just gently supporting the nucleus with the chopper and using large amount of power with very low flow rate and vacuum just to shave off the nucleus. As I reach about 50% depth, I'm going to change the settings to the chop mode. I'm going to use only the longitudinal energy. The tip goes in and buries into the substance of the nucleus. The important tip here is to pull the nucleus anteriorly towards me as the long horizontal chopper is hooking the equator of the nucleus and scoring. Important point is I don't want to be near the posterior capsule, and the bag is anyway empty. So I'm going to lift up the nucleus, and under direct visualization, the chopper is introduced beyond the equator under the anticapsule, and I'm going to score the nucleus. The nucleus division in the distal part has happened, and I'm conscious not to use excessive lateral forces to divide the entire nucleus. Using these horizontal chopping maneuvers multiple times at different quadrants is going to eventually break the nucleus. So there's no compulsion that the complete division of the heminucleus has to be achieved in the first go itself. The whole idea is to achieve the division without using excessive lateral separation maneuvers, because we're dealing with already a compromised bag, so maneuvers have to be very controlled and as gentle as possible. In the second chop, I'm struggling to crack the posterior plate because I'm not able to get a very firm grip on the fragment. I'll leave it aside and move on to the next fragment. The tip is buried, the nucleus is pulled towards the center, the chopper is introduced under the rhexis margin, hooks the equator of the nucleus, and it scores, and we have a complete separation of this fragment. I've gone back to the first fragment which had not separated completely. I'm trying to get a firmer grip and then trying to do the lateral separation maneuvers by placing the chopper at the nearer of the posterior plate. Now this is a tough nut to crack, it's taking some time. So to deal with the posterior plate attachment of this particular fragment, I just lift up the fragment a little bit more so that the posterior plate is much more anterior so the axis, and I'm using direct phaco power to deal with this attachment. So lifting up the fragment, by this the posterior attachment also moves up. By this we have an access to it. Then we can gently give the phaco power itself to detach that small posterior plate attachment, and then the fragment is free to be emulsified. Time to replenish the ovary. The dispersive ovary, that is the ovary containing the chondroitin sulfate, goes in first, which coats the endothelium. Beneath it goes the HPMC, which is not so much thermogenic, and this is the plane where your emulsification takes place. Moving on to the division of the second remaining heminucleus, the same principles of horizontal chop is being followed. Now this is an hypermature Morgagnian cataract, and because the bag is empty, the visibility is not an issue. You can always pull the nucleus to the center and then do the direct chopping in direct visualization. Obviously, the lateral separation maneuvers are going to be tough because the posterior plate is going to be extremely thick, and the separating the fragment is going to take some effort. Once the fragment is free, it's time to emulsify it in a very controlled manner. Again, in these compromised situations where the bag is not so healthy, subconsciously we'll be trying to emulsify them much more anteriorly, not in the pupillary plane or the rhexis plane, which is advisable. And that's the reason why the endothelium will be bearing a lot more brunt than regular case. I repeat the OVD injection after emulsification of each fragment. That is my preferred practice in such cases. The most difficult part of the surgery is done, that is dividing the nucleus in this capsular bag. So once we have got smaller fragments, the job is much more simpler now. Just need to emulsify these fragments. Again, there's a lot of turbulence is being noted, so it's important to slow it down and ensure that the lens shatter and turbulence is minimum and it's emulsified in a very controlled manner. So eventually all the fragments could be emulsified very easily. Time to remove some of the cortex which is there. Where a little of it is there, gently it is aspirated out. Time to implant the lens. The capsular bag is filled with OVD and a single piece hydrophobic lens is being placed into the bag. OVD both in front and behind the lens is aspirated out, and time to close. So these are the first day post-op pictures. There is obviously some amount of corneal edema is there. It's going to resolve over a period of time. And this is the third day post-op picture. The anti-glaucoma medications are stopped after 1 week of surgery, and the pressure are normal even without medication. Patient has a significant improvement of vision and she's quite happy. To summarize, in these complex cases, if we break down the complexities into individual situations, we can address them in a much better way. And it's always better to have backup plan 2, 3, 4 ready to resort to in the event of an intraoperative complication. That's it. Thank you for watching and hope you found this helpful.